Hi, my name is Jason Coe. I'm one of the attending physicians in the UC Irvine PM&R program. In this next set of videos, we're going to be talking about some of the more common urgent injuries into the lower extremity and their sideline management. But before I begin talking about some of the urgent conditions that can occur in the lower extremity, I want to briefly touch upon several emergent conditions, injuries that can occur in the lower extremity that may require immediate stabilization and transport to the nearest hospital. Number one would be an open or a compound fracture of the lower extremity, a femur or tibial fracture. This is where the bone fragment is actually sticking out of the skin. These carry a very high risk of wound infection as well as osteomyelitis. And you typically will need to immobilize the area, transport the patient to the nearest emergency room for treatment. Bear in mind that if a patient does have a compound fracture, you may not always see the bone sticking out of the skin. However, sometimes the bone can retract back underneath the skin. In those situations, you want to have a high clinical index of suspicion for a fracture if there's broken skin overlying an area of suspected fracture. Number two, a case where you have an uncontrolled hemorrhage. Femur fractures, typically very vascular, pelvic fractures even more so. It's not uncommon for patients who have pelvic fractures to require transfusions in the emergency room. So in these cases, you want to apply direct pressure to wherever the bleeding source is, attempt to control the bleeding, immobilize the region, and then transport to the nearest hospital. Number three, acute compartment syndrome. These are most common in the lower extremity with tibial fractures and even severe contusions of the lower extremity. Bear in mind, you won't always see the 5 common P's of compartment syndrome: the pain, the pallor, the paresthesias, the pulselessness, and the paralysis. But what you will commonly see is 1, pain out of proportion to the injury that's suspected, and then 2, pain with passive range of motion of the lower extremity. In a case of a suspected acute compartment syndrome, immobilize the region and transport to the nearest hospital. In this next segment, we're going to have the assistance of Dr. Revik Vartanian to assist us with the performance of the physical examination of the downed athlete. Upon arrival to the downed athlete, you want to assess their level of the consciousness. Are they alert? Are they oriented? Are they able to follow your commands and answer simple questions? At this point, you want to ask the patient, what was the mechanism of injury? Where does it hurt them? Are they able to move the joint volitionally? At this point, you want to begin your inspection of the extremity. In this particular case, we're going to start with the hip. Initially, we're going to look for any kind of gross deformities, any kind of malalignment, any skin tenting to suggest an underlying dislocation or a fracture. You want to look at the positioning of the lower extremity. In the cases of a hip, in the cases of posterior hip dislocation, the extremity is going to be adducted, internally rotated in this position here. If the extremity is abducted and externally rotated, this would suggest more of an anterior hip dislocation. If the extremity is shortened, abducted, and externally rotated, this may suggest a femoral neck fracture. Next, we'll go on to the palpation of the lower extremity. In the hip, you really want to assess the pelvis structures first. Do a brief trauma survey by applying direct pressure to the anterior superior iliac spines, creating a gentle rocking motion. If this elicits any pain, any crepitus, this may suggest an underlying pelvic fracture. Moving your way down, you may, with the heel of your palm, palpate the pubic symphysis. Again, this can be a sensitive area for most patients. Any severe pain or crepitus may indicate some sort of underlying fracture. Next, you want to move to the greater trochanters, palpate those regions. And again, palpate along the femur to see if there's any tenderness, crepitus, or any kind of instability that you know. Next, you can assess their strength and range of motion. Have the patient move the extremity, have them move into hip flexion, into abduction, abduction, internal rotation, or adduction. Next, you want to ask the patient to move their hip. Can they bring their knee up? Assessing hip flexion. Have them push out against your hand, assessing adduction. Have them push in against your hand, assessing adduction. And then push down, assessing their ability to flex or extend the hip. Next, you want to perform a thorough neurovascular exam. Start by palpating the distal pulses. You may have to remove the patient's shoes and socks to do this. So first assess the dorsalis pedis pulse on the top of the foot. and then the posterior tibial artery behind the medial malleoli. You want to ensure that the patient does indeed have good pulses. And then lastly, you want to check capillary refill in the toe and the nail bed. You should see blanching and return of pinkness within 3 seconds. Next, you want to test their sensory functions as well as their motor functions. For the femoral nerve, you want to see if they can contract their quadriceps muscle and straighten out the knee. And do they have sensation along the anterior thigh? Next, the obturator nerve. That's going to assess the hip adductors. See if he's able to move his knee towards the midline. And then you also want to assess his sensation along the medial thigh. Moving to the lower leg, you want to assess the function of the common peroneal nerve by having the patient resist your eversion and also test his sensation along the lateral malleoli. To assess the deep peroneal nerve, you're going to have the patient extend his big toe and test the sensation between the web space of the first and second toes. And finally, the tibial nerve. This is easily assessed by having the patient plantar flex or push down on the gas pedal, and you'll test their sensation in the sole of the foot. And if there's any question, you can always compare to the uninjured side. Next, we'll move to the examination of the knee. Pertinent surface anatomy you want to palpate are the femoral condyles, both the medial and the lateral, the patella, the tibial tubercle where the patellar tendon attaches, the joint lines, the tibial plateaus, the fibular head, and the medial and lateral collateral ligaments. If you suspect fracture, then you want to immobilize the knee and transport for x-rays. Next, you want to assess the extensor mechanism of the knee by having him straighten out the knee and contract his quadriceps muscle, and palpate along the quadriceps as well as the patellar tendon for any defects. Then you want to assess the major stabilizing ligaments of the knee. First, by valgus and varus testing, you can assess the medial and the lateral collateral ligaments, and the anterior and posterior drawer test, or the Lockman's test. Finally, you want to perform your neurovascular exam, similar to what we did in the examination of the hip video. Next, we'll turn our attention to the injured ankle. Pertinent surface anatomy you want to palpate will be the distal tibia and fibula. Give them a nice good squeeze in the mid-calf to assess for any kind of syndesmosis injury or high ankle sprain. Move your way distally and palpate the medial and the lateral malleoli for any bony tenderness. Palpate the sinus tarsi, the base of the fifth metatarsal, and your lateral calcaneal fibular ligament, as well as the medial deltoid ligament and the Achilles tendon. Next, we'll assess the ligamentous stability of the ankle by testing the anterior and posterior drawer test, the Taylor tilt test, the Kliger test, interplantar flex position, and external rotating the ankle. You'll test the stability of the deltoid ligament. In a dorsiflex position and externally rotating the foot, you'll test the integrity of the syndesmosis ligament between the tibia and the fibula. Finally, you want to perform your neurovascular exam, similar to how we did in the examination of the hip and the knee.
My name is Dr. Ravik Vartania. I'm one of the PGY2 residents from PM&R program at UC Irvine Medical Center. I'm going to be talking about immobilization and splinting of the joint. When it comes to immobilization, it's very crucial to immobilize the joint above and below the joint level. And also splinting, you want to splint the patient or the athlete in this case at the level where you found the patient in. In this scenario, we're going to be utilizing the vacuum immobilizer. It is crucial to not splint too tightly, as this can compromise neurovascular function and result in swelling or ischemia of the limb. For hip and femur fractures, it's easiest to spine board and immobilize the hip femur dislocation unless you have a femoral traction splint. This is an example of a vacuum splint for ankle. With this vacuum device, it's also crucial to be able to fully gain immobilization by taping over the opening of the vacuum device. And also we're using a clamp here with this particular device to maintain the vacuum. This particular splint is known as structural aluminum malleable splint, also known as SAM splint, which can be used to immobilize the lower extremity such as an ankle. Posterior and stir sweep type splinting is also utilized. We are also putting a tape over this type of splint to make sure the splint stays in place. General rules for dislocation reductions. Attempt reductions. However, the patient may require sedation in order to effectively reduce the dislocation. Do not hold transport if you are unable to reduce the dislocation on the field. It's urgent to reduce due to the risk of avascular necrosis. The longer the hip is dislocated, the higher is the risk. For hip reductions, you can utilize either one or two persons technique. In two persons technique, as in this scenario, patient supine on his board. One person holds down the patient's pelvis while the second person places the patient's calf over their knee. Using the lower leg as a leverage, push down on the patient's distal leg while pulling from behind the knee to apply more traction to the hip. You should feel a clunk when femoral head is relocated back into the acetabulum. For knee dislocations, there's a high risk for neurovascular injury to the popliteal fossa. Urgent reduction. Look for evidence of ischemia or compartment syndrome. Anterior or posterior dislocations described by tibia in relation to the femur. This can be done with one or two people in the field. Patient is supine with the knee flexed in 30 to 45 degrees. With the anterior technique, the examiner provides tibial traction and anterior force to the proximal tibia while slowly moving the knee into extension. Now we're going to be demonstrating patellar relocation. First, we're going to extend the knee and apply medial directed pressure to the patella for lateral dislocation. If knee is fully extended and the reduction still does not occur, then you can also elevate the leg and flex the hip. First, grasp the dorsum of the foot with one hand and calcaneus with the other. Then apply traction while in plantar